all here. My name is LauraTKelso. I'm an associate real estate broker with a company called Next Home Champions and the creator of this series. So grateful to have you here. So thankful for all of my regular attendees who come month after month, just knowing that they're going to get a lot of good information with no sales pitch. And a super big welcome to everyone who's new. So if you're here for the very first time, I just really hope that you're going to get great information, that you're going to find it helpful, and that you're going to keep coming back and also bringing your friends. So today we're going to talk about being proactive. There are so many things in life that we just don't have control over. I feel like I'd be remiss if I didn't say today my heart just goes out to everyone on MSU's campus and everyone that has loved ones there. My husband and I graduated there. Our son went there. We have many friends with children there. So if you're a person of faith, please be praying for them or just keeping them in your thoughts. Today mostly we're going to focus on health items. Health items can really derail us. About 3 years ago, I slipped on the ice, broke my ankle, ended up with, being on the couch for 3 months. It was miserable. We saw COVID that just devastated families. We've seen other people that have had cancer and other horrible diseases that, frankly, we just don't have control over those things. They can come out of nowhere and absolutely change our life on a dime. But today, because this whole series really is about being proactive in every way, we're going to focus on what we can do. We're going to focus on the things that are out there that can actively help us stay alert, stay healthy, try and ward off as many of those things as possible. We're also going to talk about some of the tools and tips that can help us still, bring joy to our lives and help our senses even when they start to fade and even as our bodies start to change. I want to make sure that you guys can all get the same amount of joy out of the things that you used to do, whether those are social gatherings, whether those are reading books, hearing music, different things. The goal is always to have you live your best and healthiest life by what you learn here. So with that in mind, I'm going to go ahead and I'm going to have our amazing panelists introduce themselves, starting with Christina.
Hello, everyone. My name is Christina Hedlich. I'm an occupational therapist at West Michigan Eye Care Associates. I specialize in working with individuals with vision issues or low vision, and I have a passion for that, so I'm going to speak about that today when we have the panel.
I'm Dr. Pam Keenan. I'm the owner of McDonald Hearing Services, and today I'll be answering some questions about hearing and hearing health. And I think it's just really important to stress hearing is a part of the senses as well as vision, and it's what connects us to people and to community. And so hearing loss, I think, goes kind of by the wayside, and people kind of poo-poo the importance of it, but I'm going to show you today in answering some questions, the very, very integral part. There's a lot of comorbidities that go along with hearing loss, so I think I have some good information for you today.
Good morning, I'm Kelly Pines, and I am the clinical director at Home Rehab, which is a home care company. I'm also a physical therapist, so I go to people's homes and provide therapy for those that have challenges getting out of the home and getting to a center instead. So today we're going to talk about falls, preventing them from happening, staying independent in your own home so that you don't have to move out of your own home. So independence, independence, independence.
My name's Jared Adams. I work for Caption Call, and I'm an account manager. We've created a phone for people that so they can read what they can't hear on the telephone. So we'll be talking about device that can help you communicate better on the telephone.
Thank you all. All right, we're going to go ahead and we're going to get started with Christina. So like everything else in our bodies, our eyes most definitely age. I've finally gotten to that point where I can't read anything without little glasses, and so we have them all over our house until I finally give in and get permanent ones. But what would you say is the most important thing that we can do for our eyes to stay healthy?
forgive me for reading some of my notes. I'm trying to keep us on time with my answers. The biggest thing is regular comprehensive eye exams. And for everybody who has completely healthy eyes and no glasses or contacts, I would say every 2 years is appropriate, unless you have some other eye issue. We start with eye exams as early as little babies, and our doctors at our office actually provide and encourage new moms to bring their babies in about 9 months, so before their first birthday, to have their first check. Kids usually get checkups or should get checkups through school age, but especially if there's issues with seeing the board, encourage them to go into their eye doctor, because that's a common thing with kids needing glasses to see the board and to read. Anybody who has glasses or contacts, you should be seen on a regular basis, because that obviously does progress sometimes and change, and you need that in order to get an updated prescription. As we age, after 50, I encourage everybody should be getting regular eye exams probably every year or two, especially more frequently if you do have a diagnosed eye problem. Glaucoma, diabetes can affect the eyes, or any other cataracts or other conditions that are progressing. And just come back to the office as your eye doctor indicates that you need to come back.
Great. So we all know that living a healthy lifestyle in general, helps us. But I never really equated the idea of just a healthy lifestyle truly being very specific to eye health. So what are some of the specific things that go along with a healthy lifestyle that are absolutely critical for us to maintain healthy vision?
As everybody always says, for everything else in your life, a healthy diet, that's a prime thing. If we're feeding our bodies correctly, then our eyes are getting fed correctly. It helps prevent a lot of things. Protecting your eyes, if you're doing yard work, if you're doing work in your workshop, if you're cleaning your house with different chemicals, it's good to have some eye protection, whether it's your regular eyeglasses or safety glasses. Also, sunglasses outside. Good to protect your eyes from UV rays. If you do normally wear glasses, nowadays all of those glasses generally and contacts have some UV protection, but to prevent glare issues and so you can see the best, having some sunglasses on is good. Reducing or eliminating, if possible, smoking. That is a big factor in eye problems. Exercising is always good. Controlling your blood pressure and controlling your blood sugar.
How about anything this wasn't on the sheet, so like looking at computer screens all day long. Are there anything specific that can really help people as they're doing that?
There are a lot of blue light blocking options for your regular glasses that you can opt to use. That's helpful, especially if you're on a tablet or things into the evening. There's a lot of settings now in computers and on tablets and phones that you can turn on in the settings to reduce that blue light at a certain time as the sun goes down. That's always helpful. But making sure that you're not overstraining, that you give yourself, like every 20 minutes, look 20 feet away for about 20 seconds is a good rule of thumb to keep your eyes healthy and not be focused on those screens intently for too long.
So what are some of the most common eye conditions that you see on a regular basis? And for some of these conditions that are actually hereditary, are there things that we can do proactively to keep that progression at bay for things that run in our families?
I would say the three most common ones we see are age-related macular degeneration, glaucoma, and diabetic retinopathy. So age-related macular degeneration, much of it's very similar with genetics to getting other medical issues. You have possibly a genetic tendency from your family members, but things you've done in your past or throughout your health or throughout your life could affect whether you trigger that gene to turn on in some individuals. Some families it's very strong and we see many family members with it. Some people I worked out in the sun outside most of my life and I never wore sunglasses or a hat, and that was the trigger. Some people it's smoking, some people it's other things, but there is a lot of advancement going on with macular degeneration. There are some vitamins you can take that you can speak with your eye doctor about, or your retinal doctor, that sometimes can help slow the progression if you do have it. But it's something that eventually everybody's going to have some form of macular degeneration, or at least a majority of us, if we live to 100. So unfortunately, some people get it a lot younger than others, but there are ways to slow it down. There are ways to keep yourself healthy. Eating, like how I mentioned, some of those other options, not smoking, can really play a positive impact on that. Glaucoma, if you know a family member has it, make sure you're getting your regular eye exams, and if you do have higher pressure and they tell you you need to take eye drops, even though you don't feel anything, take the eye drops. They are keeping and saving your vision. It's a very painless, unknowing disease that can rob you of your sight. Shouldn't be something that you just poo-poo because you don't feel like you're losing your vision. Diabetic retinopathy doesn't happen to everybody who has diabetes, but it's a good thing to be checked. It's something your doctor should be looking at every year if you do have diabetes, and there are preventative measures, especially with managing your sugars.
What is, I can't say that word, diabetic?
Retinopathy.
That.
Diabetic retinopathy is when the film of the back of your eye has kind of like the film in a camera, I would say. It's called your retina. And there's many layers to it. And when you have diabetes and your sugars are too high, the response your body has is it starts making its own extra blood vessels, because with the higher sugar, your retina is starved for food. It's not able, because the sugar molecules are taking up so much area, they can't bring the proper food in. And so it starts branching out these little blood vessels that really are useless, and then they start leaking. This leaking leads to extra fluid in the back of your eye, or swelling, which makes these layers, the multiple layers, come apart, and it can cause scarring, it can reduce your vision, and cause you to have other medical treatments to arrest it or stop it. But you will have some vision loss from it if you don't take care of it.
Okay, thank you. So how about some things that would be considered absolutely an eye emergency? So what are things that might happen where if they feel these symptoms, that they're not ignoring them, they're going straight to an urgent care or calling their eye doctor?
I would say any sudden change to your vision, a vision loss that's very sudden, you need to get help immediately. Any flashing lights, halos, feeling like there's a curtain falling, those are indications of different eye problems that can be taken care of, but should be taken care of right away. Whether you contact your regular eye doctor, who, if they're a comprehensive eye doctor, they should have somebody on call that can direct you, whether you can come see them in their office, even on the weekend, or whether they direct you to go to immediate care. You should get checked out. Any eye pain, you should be making an appointment right away. If you get a foreign object of some sort in your eye, even your regular optometrist can at least be the first person. Sometimes they can even remove some of those items if needed, or give you proper care. So you don't think you have to go to immediate care all the time if your eye doctor is open and able to take care of you. And then any eye redness with discharge, or unexplained eye redness that keeps on, that's not going away, then your eye doctor could help you with that too.
So much of our series focuses on ways that seniors can stay independent as their bodies age. So what are some very specific things that we can do in our homes to help us compensate and stay safe as your vision decreases?
This is my area of expertise because I deal with this all the time. The biggest thing is lighting. So you can increase lighting in many different ways. There's a lot of neat things out there. Whether you want to go to Menards or whether you're an Amazon shopper, you can find a lot of rechargeable, easy to put up lights for your pantries, for your closets, for your stairways. It can be a huge help just having good lighting in your areas, so that you're not tripping and falling, and so that you can locate the items without having issues tripping over things in your closet or whatever. Also, if you do have vision problems, some people find using a contrasting color for part of your decor or to locate objects can be helpful, like if your whole wall is white and your light plate is also white, changing that color up so you can find the light switch easier. Just using a different color shower curtain. If everything's all white, you're not gonna see the curtain as well as if you use a more decorative one, things like that. Another thing that's come out recently, and this is my last point, is the use of smart home technology. If any of you are agreeable to use like an Amazon Alexa or something like that, it can be a huge help for people who have vision loss or who are aging. It can save you some time. You can use your voice to set timers, to make lists, to be able to operate lighting, to listen to books, and keeping your calendar up. So it's a time-saving device, but it also can be helpful in a pinch. I've had people even make phone calls with that. So it's very helpful.
We've switched over to Alexa in our house as of a couple years ago, and I thought it was kind of hokey when we first did. I'm like, really? I can't turn on my own light? And now I've become so used to it. It really, really is convenient to have her turn on lights and radios and so forth. So it's been kind of cool. Okay, so we're going to move on to Dr. Pam Keenan. She's the owner of McDonald Hearing Services. So I know that hearing loss runs in my family, right, people? How much of hearing loss is hereditary, and are there also things, really similar to the question I asked Christina, that we can do proactively to stop that progression, even if it runs in our family?
So I think this topic, we need a little bit of clarity because it's kind of a overarching concept talking about hereditary. So there's two different categories. There's congenital and acquired. Congenital is you're born with it. You were born without hearing. So something happened either genetically or in utero to cause the hearing loss. The acquired is something that develops after that. The other thing to differentiate is syndromic versus non-syndromic. So syndromic hearing loss, you have other outlying conditions that are also affected other than the hearing. So there's like Usher's syndrome, Warburg syndrome, neurofibromatosis, things like that. Those are syndromes that you would be actually diagnosed with. The non-syndromic are other conditions that are just maybe a genetic issue. Familial is more than one person in the family having that condition. Sporadic is maybe one person, and it's just one person in the family or a person here or there. So there's a difference between predisposition and heredity. Again, like a lot of other things with the eyes, heart, things like that. If you have a lot of people in your family that have it, you're more than likely than somebody else to potentially have it. It doesn't mean that it's hereditary in the fact that it's a genetic issue. So if it's the sporadic type, which is what most people have, so it's not really genetic. Now, the only way to be proactive about it is there is genetic testing now. So there are ways for these syndromes and the birth issues to be avoided or mitigated by genetic counseling. Other than that, it kind of goes along with what you were saying, good overall health, well-being, blood flow, blood pressure, oxygenation, all of those things can also affect the hearing loss. The number one cause of hearing loss is actually noise exposure. So there are a lot of people in your family that may have hearing loss, but you may be able to connect that directly back to their way of life, a lifestyle, a work environment, things like that. And then, as I mentioned, the comorbidities. So diabetes, because it affects nerves, it can affect the ear as well for the same reasons. That sugar kind of takes over, it's not letting the nutrients through, and eyes, like ears, are highly, highly vasculated. One quick blip of disruption of blood flow can be catastrophic. And then there's ototoxic medications. That's something that you'd want to discuss with your physician. When I say only, there's hundreds of thousands of medications out there. There's about 200 that are actually ototoxic, meaning they will damage your hearing directly as a result of taking them. So you'd want to ask your pharmacist or your physician about that. There's a lot of medications that have a side effect of ringing in the ears, but not permanent hearing loss. So you just want to be careful about that. Some of the really common ones are blood pressure medications or Lasix, Bumex. They're the diuretics that can be given. High doses of aspirin can be troublesome. But obviously, do not stop taking anything without consulting your physician, because sometimes they can just reduce the dosage if you're starting to get those symptoms.
That's something I don't think I really would think of. So it's good to hear that. So please take us through what would happen during an initial appointment in your office when someone comes into you for hearing loss. How do you determine if a client is best suited for hearing aids, or if there might be other measures that would help them with their hearing loss?
Absolutely, to reinforce, everybody should get a baseline audiogram by the time you're 40, 45, because anything, medications that you take, accidents, anything that could happen, you don't have anything to reference back. So it's like a mammogram, vision, everything else. You want to stay up on those and track any progressions and trends to see what's going on. So definitely everybody get an audiogram if you haven't already. The first thing we start with is a questionnaire. So we're going to ask you and potentially a spouse or a loved one how you feel the hearing loss, or if you feel there is hearing loss impacting you. Then we get a really good medical history. So again, we're looking for the ototoxic medications, heredity, diabetes, things like that that could be contributing. Then we're going to do what's called otoscopy. So we have a fiber optic camera. We're going to go down into your ear canal, check the health of the external ear canal and the eardrum. That's all the farther we can see from the outside in. We want to make sure that's all intact. There's no foreign bodies, no wax, anything like that to be managed. If that's all clear, then we move you into a soundproof booth where we do a hearing test. All of this is painless, and it does not really take very long at all. We put you in a booth. You're just going to answer some questions. You're going to push a button when you hear some beeps. We're going to establish where you just hear sound, how you hear in speech and quiet, speech and noise. We're going to go through all of those processes to rule out any underlying medical conditions there may be, and then to determine the type and degree, the diagnosis, or what I call your ear story. Once we're done with that hearing test, we bring you out of the booth, we review that ear story, go through any more questions or concerns, and then we develop a treatment plan. Now that could look different for everybody. It depends on the type and degree of hearing loss and where your difficulties are. Sometimes it's as simple as just referring people to get some earbuds to put in to stream TV. If it's just the TV, that's a problem. If it's something that's more of a serious problem, it may involve hearing aids or amplification of some sort. If not just that, sometimes we have to couple assistive listening devices along with hearing aids. So it depends, again, on what you're trying to accomplish as a goal for better hearing and what your environments are. So it's very, very individual. And that's where the hearing aids that we dispense are a prescriptive hearing aid. So that's going to be something that is tailored exactly to you and your needs.
Makes a big difference versus buying them off the shelf, so to speak.
Yeah,
Right.
and just a quick comment about that. Over-the-counter is not the problem. It's when it's applied to the wrong situation. So as long as you read through on those packaging and be sure that you're checking off yes to all of those questions, it may be a start point. They're designed for fairly mild situations, and if you're not somebody who thinks it's an everyday, all-day situation. But I pose the question, how do you know you have a hearing loss? How do you know there's not something in your ear preventing it? How do you know that you don't have an underlying medical condition? So I would definitely strongly encourage people to still come in and get an audiogram, a thorough hearing test by a hearing specialist. Most insurances, if not all, cover it at this point. So as long as you have health insurance of some sort, which most of you all are going to have Medicare, they do cover. We just need a referral from your primary care, no big deal. But I would definitely encourage that.
Great. So what are some of the typical conditions that would actually warrant a trip to the ENT versus an audiologist? And really also some red flags that people should watch for that would also, alert us to something serious.
Kind of as I was listening to her, kind of similar to the eyes, the most emergent situation would be a sudden onset hearing loss. All of a sudden, boom, you wake up one morning or partway through your day, the hearing goes dramatically down in one or both ears. That is a trip directly to the ER. It's kind of like the medication they can give you when you have a stroke. You have a time window in which they have to give you some sort of a steroid to even potentially reverse this issue. Do not overlook it. Do not poo-poo it. It could be just simply wax, but won't you be relieved? You definitely want to get that checked right away. Obviously, any pain, itching, drainage that persists, you want to get in. That could be an urgent care, that could be a primary care visit. That isn't necessarily ER level unless the pain, obviously, if somebody's jabbed something into your ear, something obvious like that, you want to get in right away. If you're just wondering and you're not really sure, you could come into an audiologist as well. We can look for any warning signs of what would need to see an ear, nose, and throat specifically. Most ear, nose, and throat doctors have audiologists on staff. They're not doing the testing. So if it's just questioning hearing or gradual changes, we would be your first line of defense. If it's more of a medical issue, potentially, you'd want to get right into them. We, as doctors of audiology, the FDA has warning signs out there. Unfortunately, as a caveat to this, those are no longer enforced because of over-the-counter hearing aids. So there are no red flag requirements of people to report. So it's a visible abnormality of the ear, active drainage in the last 90 days, cerumen or a foreign body, ear pain or discomfort, acute or chronic dizziness, or what I would diagnose as an air bone gap. And then that sudden onset loss. Those are the warning signs we're supposed to be looking for as a provider, and then can get you the referral to the proper location.
I think sometimes, having a professional that can spot something that we would never, spot ourselves. This is kind of off topic, but my mother-in-law actually had colon cancer a number of years ago, and the way that they spotted it was a dental cleaning. She went to a dental cleaning and they noticed that her gums were not looking right. They sent her immediately to the ER. They immediately admitted her for surgery because that was her signal that she had fairly advanced colon cancer. And
yeah, there are a lot of things underlying in the audiogram that we can see too that are heart related and things like that. Another thing you want to watch for is what we call pulsatile tinnitus. That's a ringing or a buzzing or whatever you want to describe the noise in your ear, and it moves with your heartbeat. That is a big warning sign that you may have a carotid artery issue or a blood flow issue. It could be nothing. It's, again, structures are different between people, but that's another one that you would want to get in right away and ask your physician about or mention it.
Great advice. So how about cochlear implants? I know we've heard a lot about those in the last few years. How do they work differently from hearing aids, and what types of patients might be best candidates for implants versus hearing aids, and also a little bit about the cost?
Sure. It's a big topic, and this topic could take itself a whole day, but I'm going to just kind of touch on some of the main bullet points. The cochlear implant is different from a hearing aid in that it is surgically implanted. So once we have determined that your hearing loss cannot be improved with amplification, and there's what we call a 60-60 rule. You have more than a 60 decibel average hearing loss and more than 60% loss of word recognition. That's just the criteria to get tested to see if you are a candidate. There are several categories that they're going to be looking at besides just hearing before they even determine that you are a candidate or not for it. So as audiologists, we know the warning signs. We actually work with cochlear implant patients as well. So once that hearing loss starts to progress to a certain point, we start the conversation because you want to be well informed. This isn't a decision you want to make when your back is to the wall. You want to just be aware. And so it is an electrode that is going to go into the cochlea. So it's going to go into that little snail-shaped object in your ear, and instead of an acoustic and a fluid, it's an electrode, so it's an electrical stimulation to the ear. So it's taking the place of the cochlea, and it's going to send the signal up to your brain where the actual hearing and discrimination happens. So it is different in that case. It is not scary like people think. I mean, it is surgery. You don't take it lightly, but it's outpatient. So those gruesome things and visions that you saw 20 years ago of what this is not it at all. And it can be life-changing. I've had people wait too long, and then, things progress, then you're not healthy enough to do the surgery. Who wants to be absolutely in silence at the best years at the end of their life? So it's definitely something you want to think about. So you'll be determined if you're in the criteria, they'll do a test battery on you to see if you fit all the needs. Then they will send you to meet with an ear, nose, and throat doctor and talk about all the specifics. Because there's a lot of individual differences, and there's a couple of different companies, and there's different reasons why they would go with one versus the other. So they're really the experts in that part of it. But there are local organizations that get together different times of the year where you can just go and you can talk to other people who have been implanted, and surgeons and other care workers that can help you in this process and get factual information. Because again, I feel like there's a lot of misnomers out there about cochlear implants, but it is not something that replaces hearing and replaces hearing aids. It's still highly recommended you go with the best technology you can out there first, and that is part of the requirement to then move on, because they want to be sure that, as sure as they can be, that the cochlear implant will be better than you do with your hearing aids. So you exhaust your efforts with the hearing aids, and again, if you're under the care of an audiologist and we're tracking that hearing loss year to year, we'll start to have that conversation long before it's a necessity, but we'll start introducing that concept to you.
Great. And this final question kind of builds right on that. So there's really been a ton of advances in hearing aids, but I know people who still continue to struggle, especially when they're in different social settings with lots of competing sounds. So are there new technologies or even strategies that can help people with hearing loss really enjoy themselves still in those social situations when there's a lot going on?
Absolutely. Now that's a loaded question too. But just to piggyback back, probably people are wondering, I didn't talk about the cost. Medicare covers cochlear implants. Now, again, you need to meet with your physician. They'll figure it all out. They'll pre-qualify all of it for you. But most of my patients have zero out of pocket for this. So it is something that they, at each of these individual doctor's office, work very hard to figure that out all for you, and you pretty much know down to the penny what it could be expected. So there are other types of ear surgery for for specific types of hearing loss. So if you're determined through the diagnosis that we did that your hearing loss is truly just a medical issue that could be surgically fixed, we refer you out. There's things called bone-anchored hearing aids. There are things called stapendectomies, where they go in and they replace some of the middle ear bones. And that's from otosclerosis. So that's, again, another specific kind of a medical issue that we can detect with the testing. So there's probably about 5% of my patients that actually have some medically correctable type of hearing losses. So new technology could not be any more exciting. I've been an audiologist for 30 years, and I never thought we would be where we are with hearing aids. But again, it circles back to the type and degree of hearing loss and what your word recognition abilities are. And then there's my favorite saying, hearing is a gift, listening is a choice. And you have to be an active listener. You have to be engaged. You can't sit back in the room, close your eyes, and the hearing aids are going to bring everything to you. You have to participate in what unfortunately happens as hearing loss progresses slowly. We withdraw, we pull back slowly. We don't always notice it at first, and by then we've become an inactive listener. Now we've got to reactivate that listening along with the hearing aids. So that's where the hearing aid is an integral part, and we now have fantastic technologies that have directional microphones, noise management, all these things to try to capitalize on the best parts of what's remaining of your hearing. We're using what's left of your hearing to help you hear. We're not regenerating anything, we're not replacing anything. So to take somebody, let's for example, with a 60% word recognition score and go to 100, is impossibility. So you have to be realistic, and you have to know your type and degree of hearing loss and what's going to happen, and then pick that appropriate technology. And it's very important that you pick the provider versus the technology. And what I mean by that is this is going to be a relationship like your primary care, your dentist. You want to be able to trust them. You want to go in, you want to get good service, and you want a good feeling. So go in, and most places should offer a free consultation just to come in and meet someone, because you want to pick that individual and be confident in their knowledge. We have hearing aid technologies now that do language translation. They'll fall detect. They'll check your blood pressure, your heartbeat. They're gonna do blood sugar here very shortly. So anything my Apple Watch does, your hearing aid can do in your ear now. So there are some fantastic things, and there's ways to manipulate the environment with your app on your phone to you pick where the microphones are focusing in that environment. So you have a little bit more control if you want it, or we can make them more automatic. But if you haven't tried hearing aids in the last 2 years, by far, hands down, this year, do it. Just demo them and try it for yourself. They are life-changing. I've never seen the results that we're getting like we do now. Again, it's not perfect, and if you have a trickier hearing loss, we may add other devices along with it. Remote microphones, TV streamers, things like that that can affect that environment. Because if your word recognition is low enough, we can give you a little remote mic, you clip it on. Like right now, I could have it on and I could have patients in the audience. They push the button to their hearing aid and they're gonna hear me like I'm right in their ear with earbuds. You can stream your audio books, your music, all kinds of things. So if you haven't looked at it, go in and at least get a consultation and look into that new technology.
That is so cool. I mean, it really is very encouraging to know that these things are out there and that technology is continuing to get better and better. And as we're talking to these guys, it's just that constant reminder of, doctors of all types, financial planners, lawyers, realtors, all these people in all these different areas. Just find one that you know, like, and trust. It just makes sense. That is not gonna, charge you an arm or leg when you call for a question. These are people that should be supporting you in your journey, whichever category they're in. So we're gonna go ahead and we're gonna move on to Kelly Pines. She's clinical director at Home Rehab. So Kelly, let's talk first about the many things that your company does, because according to your website, I mean, there was just a ton. I was really surprised at the variety of things that you guys handle.
Yes, our name doesn't always give it away, right? So we provide home care services in your home, wherever it is that you live, whether that's in a house, a condo, do you live at an assisted living facility? We can come to wherever you're living or staying, and we provide nurses, physical therapy, occupational therapy, speech therapy, and a social worker. So all of those things are a benefit that anybody who has a Medicare or a managed Medicare has this as an option for them. It's often called home care, and oftentimes people will hear the word home care and they think this is someone that comes to my house and helps clean it. We don't do that necessarily. I would like one of those people to come to my house too, but we don't do that type of home care. We provide the medical care and rehabilitation in the home.
So who qualifies for your services, and is it generally covered by insurance? So is it really anyone who needs physical therapy, or are there people that must be eligible to receive it in their home versus having to travel out to a doctor's office?
Great question, and this is a question a lot of people ask. So there is a criteria, and the criteria is a very gray answer. We always want it to be a black or white answer, and it isn't. It's very gray. So in order to qualify for someone to come to your home, there has to be a physician, your doctor has to say, we need someone to come to you. It also has to be challenging for you to leave your home. And challenging is a defined word that is defined for each individual. So it may be challenging for one person just to go up and down steps to exit or enter their home. That would qualify them. It may be very challenging for a variety of different cognition issues. It may be very overwhelming for someone with dementia to leave the home and go to a very busy clinic. It also could be that you have a respiratory disease concern. You're at risk for something. You're undergoing chemotherapy and you are not able to go out into the public as safely as you once could. That would qualify you. So there's no magic answer. Everyone that has Medicare or a managed Medicare has this benefit, and most Medicare and Medicare Advantage plans cover it 100%, which is very different than going to an outpatient therapy center. That's a different part of your insurance that you use. Having it in the home is a very different part. So they operate very different from each other. So if you are look at your plan and you see, I'm gonna look up what does physical therapy gonna cost me? That is not the type of services that we have. That's going to a center and getting those services at a center. When we come to you, it's very similar. It's a different thing. That is called your home healthcare skilled benefit. So that's where you would find that within your insurance.
That gets pretty specific, so always good to have a person to ask questions. So one of the most challenging things that I see among seniors are the results that can happen from a fall. Tell me about how you guys screen seniors for their level of fall risk, and how do you work with them to both maintain their muscles and their balance that can help prevent a future fall?
This is a great question, because this is what I see every single day. I see people that are falling. They're either falling publicly and everyone knows they're falling, or they're secretly falling and not telling anyone that that's happening, or they're at risk of falling, all of which are very dangerous, as we all know. Show of hands, how many people know someone who's fallen and broken a hip? So when we look around the room, we see that that is a very, very serious injury that comes from falling. And falling is one of those great things that can be prevented. So the things that we do to screen. So I actually specialize in fall prevention and balance dysfunctions and such. So I come in and look at a variety of different things. The first most obvious one we look at is, how is your home set up? What does that look like? Do you have enough room to get your walker into your bathroom? Maybe your doors are not wide enough. So we look at, do you have clutter? Do you have area rugs? Do you have things that could easily cause a fall from happening? So we do that. We look at all of those external things. Then we look at internal, because we get our balance from such a different variety, several different parts of our body, which is great because we get it from our eyes, we get it from our inner ear, we get it from our muscle strength, and so it is really quite interesting. You do have to have all of those things looked at by a balance specialist. So we have to look at all of that and how you're using your parts of your balance. Which ones are you using too much? Which ones aren't you using at all? Is there a reason for it? So sometimes there are diseases, like these other two lovely ladies have mentioned. There are different things that happen in disease processes that affect one or more parts of your balance. So we may have to say, okay, this part of your balance isn't very strong. We need to work on making the other parts of your balance even better.
Great. Yeah, that's huge, because one thing I also know is that once someone has a fall and breaks something, at a certain age, it's just so much harder to ever get back to that 100% level. So the more that we can do concentrating on prevention, absolutely the better. So how does your approach change when you have a client or a patient that is struggling with cognition issues?
Yes, that happens quite a lot, because oftentimes, depending on the cognition issue, so we'll just kind of throw out the diagnosis of dementia. Dementia is very different for each and every person with dementia, right? So depending on the person, are they able to learn new tasks? Just because you have a diagnosis of dementia doesn't mean you can't learn something new. We also have people that are unable to learn or retain things because of their dementia. So it depends on where that person falls on the cognition scale, and we do some testing to determine what your ability is to learn something new. But here's the cool thing, is Even if you do not have the ability to learn a new task, or hey, I want to give you this walker to help you walk better. And we all know someone that has had dementia that is not going to use that. They're going to set it off to the side and walk without it. I see that every day. And that's okay because we have the ability. Our balance and how we respond to losing our balance is automatic for everyone everyone cognition-wise, up until the end stages of Alzheimer's. That's the only time your balance is no longer automatic. So even if you can't follow directions or your loved one can't follow directions, we can still improve their balance by affecting their automatic balance. That gets very, very challenging and exciting sometimes during a session, but it can be done. I see it happen every single day. I work on it every single day. And if we can provide, just one person from avoiding one big fall, we got to go for it.
That's great. So what are some of the things that you guys do in your company for clients to help them remain healthy and independent in their homes, and really anything else that you'd like to add?
Yes, that is the ultimate goal. That's why we come to you. We want you to be able to stay wherever it is you want to stay. And most people want to stay in their own home. Just by having someone come into your home, oftentimes the information that I get is, I don't want you to send me somewhere else. I don't want to do that either. I want you to be successful in whatever environment you live in and want to be at. So we may have to recruit some other folks, right? So our company, do we have to have a nurse come out and make sure that you are taking your medications properly? Are you taking them like you're supposed to? Are you having side effects that might be affecting your balance? And so we have a nurse that can do all of that. She also is great, or she and he's, we have several nurses. They come out too, and they can help you with your disease processes. So, hey, I have diabetes, but I kind of don't know what that means, and I'm not entirely sure if I'm doing well with it. They'll help you come up with a diet plan, with a meal plan that accommodates all of these things. So they provide as much education and training on your medical conditions that you would possibly need. A lot of times that includes discussing medications. They go back and forth communicating with all of your doctors to say, hey, heart doctor, did you know that eye doctor prescribed this? And hey, did you know that this person gave their mom an additional couple doses of this because she had some extra at home? These things happen every day. People borrow medicines, people have medicines from 1971 in their cupboard still that they take on occasion. We see all kinds of exciting things happen, and let's say that keeps our nurses quite busy. But that alone, making sure you're managing your medications successfully and taking them successfully, ultimately can help you in every area of your health. Then our occupational therapists, what they do is very similar to what we just learned about earlier. Occupational therapy, oftentimes people hear the word occupation, and then they say, I'm not going back to work, I don't need you. And it is a little bit misleading, the name. Occupational therapy, what our team does is they come in and help make sure that you are remaining independent or becoming more independent and taking care of yourself, your home, your loved ones, your pets, whatever that looks like. So that's different for each and every person too. So for the person with very low vision, like we learned earlier, our therapists come out and help you be more successful with your vision ability. If we focus on what you can do and help you be more successful, then you're likely going to stay in your home longer and forever. We want you to do that and be safe from a variety of different reasons. So our occupational therapists will help with bathing ideas, cooking ideas. Hey, did you know that if you sit on a stool and make your dinner, you will conserve so much more energy that will allow you to continue to cook as opposed to not cooking. So even though that seems like such a simple thing, they are magicians at coming up with changing up the way people operate in their own homes so that you can be more successful. Our social worker, she is an option for folks in the fact that sometimes we do see people living in conditions that are not safe. And oftentimes we have to call on her to get some more help. So whether that means we need financial help, or do we need to find a waiver program or something that allows for some additional services? Does that mean, hey, this person is living alone and really they don't want to be living alone anymore? Do they need more help from individuals? So we have a social worker that can do that. We also have a speech therapy team. The speech therapy team helps with swallowing, voice projection, and cognition to a degree as well. So anybody that falls into those categories, speech therapy is for you. And then last but not least is my favorite, physical therapy. I mean, that's because that's what I do. But so obviously then what the physical therapy does is we come in and we're looking at balance, strength, motion, pain, all of those things that that would help you be more successful to be and stay independent in your own home.
Great. I think so often we all just need sometimes a second set of eyes and a sounding board to talk about what's happening in our homes and have someone else go, oh wait, that might be why this is happening or not happening, and can be really helpful for that additional expert. So now we're going to go ahead and we're going to move on to Jared with Caption Call, and this is going to be a little bit different because this is not so much how to stay healthy, but definitely a very specific tool that people can use successfully if they've already, had hearing loss. So, Jared, while Caption Call doesn't help people avoid hearing loss, it's certainly a great tool that can help them remain independent in spite of it. So can you start by telling us a little bit of the history of how that came to be and just a general overview of how it works?
Yeah, so Caption Call started about 11 years ago. It is a federally funded program thanks to Title V of the Americans with Disabilities Act, which requires telecommunications to provide functionally equivalent access to telecommunications. So in layman's terms, the telephone companies have to provide access to those of us with hearing loss a functionally equivalent way to communicate over the telephone. And so we've developed a phone that prints the words on the screen so that people can read what they can't hear at the same time while they're talking on the telephone. If you have a hearing loss and you need captions, there is no cost for this to you. This is funded because we've been paying a fee on our telephone bill since 1990, thanks to the Americans with Disabilities Act. So we are able to come out and install that phone system for you.
Great. So who can actually qualify for Caption Call, and what does that process look like?
So anybody that has a hearing loss and needs captioning qualifies for this program. There is no decibel threshold of hearing loss. If you're struggling to hear on the telephone and you need the captioning, you qualify. So the application process, there's a few different ways to apply. One, you can see me after. I can sign you up. I'll talk to you a little bit and see. You just let me know that you're struggling to hear on the phone. You can go see your hearing healthcare professional. Almost all the hearing healthcare professionals around Grand Rapids, West Michigan, know who we are, know how to get you signed up for this program. You can discuss that with them as well. You can also go online and get signed up as well. The next step of the process is they schedule an appointment with you to have us come out and install the phone for you. They show you how to use the phone. They train you on it, make sure you understand how to use it. And then we have customer support to support you afterwards. We have 13 call centers around the United States. A human being actually picks up the phone when you call us for help. You don't have to fight with any machines or anything. We know it's difficult for you to communicate with us as is. We're not going to create any more barriers. Again, that's all covered. There's no cost for this. We've all been technically paying for this since 1990 on our phone bills. That's where we get our funding to provide this service and program to you.
So you pretty much answered all of question 3 already, so I'm going to go ahead and I'm going to skip to question 4. That question 3 just had to do with technology, being nervous, how people get it set up in their home. How long does it usually take to get it set up in a home, Jared?
The installation process in the home takes about an hour. The actual install takes about 15 to 20 minutes. The trainer comes out, they'll ask you, do you have a landline, which is not required. Do you have internet? Also not required. But they just want to find out what your lifestyle is like. Do you use a smartphone? Are you tech savvy? Are you more old school? Do you spend time in the living room? Do you spend your time in your office? This will help them understand where to maybe put the phone. If you spend a lot of your time in a recliner watching TV, then they'll put the phone there. If you spend more of your time in the kitchen baking a lot, then they'll put your phone there. So they just want to determine your lifestyle and figure out how you operate and where to best put your phone. So 15 minutes is spent determining that. The other 45 minutes really is just showing you the phone and having you do a couple of test calls just to make sure you're comfortable with it. There are some features on there, and we may show you some of the features on there, or we may just say, great, you can pick up the phone, read the words, and it works, and you can hang up. Maybe 60% of the people that we do install phones for, that's all they want. They don't care about all the other features. They just want to pick it up, they just want it to work, they want to hang up, that's it. And that's fine. We got 40% of the people want to know about the other stuff, the phone book, the answering machine, the audiogram settings that we can modify the audio on a little bit. So it's really up to the patient how they want to use the phone and how much they want us to show them.
I can't tell you the amount of things that I've purchased, and including my vehicle, that I use probably about 20% of the options of what it takes. My husband will come in and like, why are you doing it this way? I'm like, I don't know. Because that's all I know, because I did it once this time and it worked, so I'm going to stick with that. So how does caption call work if someone has both a home phone and a mobile phone? And is it possible to get caption call on both a home and a mobile if seniors have both? And what about couples that have like separate cell phones?
If you have a home phone and a mobile phone, we do have an app. We will install the home phone first, and then we would install the app on your cell phone. That way the app on your cell phone will sync up to the home phone, and then your phone book will be shared. That way if you add something in your phone book in your cell phone, it will show up in the phone book on your home phone, so you don't have to add things in both places. If you miss a call on the app and it's synced, it will show that you missed a call on your home phone as well. If you have a couple with separate cell phones, that's a good question. We can install an app on both phones, but you would have separate accounts. Or if you wanted to share, you certainly could install the app and just use both accounts, and you would have the same phone number if you shared the accounts.
Yeah, so there's definitely some nuances that might have to be, figured out depending on what your absolute personal situation is. So can you tell us any personal stories that of clients that you've worked with, people that have really come into this technology and just had it been kind of life-changing if you haven't had it before?
Yeah, I have many, many stories, but one of my favorite ones I like to share goes back to when I first started working for Caption Call about 10 years ago, and I first started doing installs, and it really changed my perspective. So I was working part-time for Caption Call at the time. I had another job. I thought it was a lifer at my other job. I was not ever going to leave my other job. I came across a 72-year-old guy whose son lived in North Carolina, and it was his only son. His wife had passed away years ago, so he was living alone. He could not hear on the phone, and he communicated. He had a full, real discussion with his son once every other year. So his son would fly to see him for Christmas every other year. That was the only time he really got to have, an in-depth discussion, because they could see each other face to face and actually talk. If you got on the phone with the son, everything was yes, no, very straightforward. And he knew his son knew his limitations, and he didn't want to frustrate his son. So there was not really meaningful conversation on the phone. And he told me this before I did the install for him. So I installed the phone for him, and he calls this kid right then and there on the spot. And he starts talking to him. His son thought something was wrong at first because Dad never calls him anymore. He said, "No, I'm fine. I'm reading the words on the screen." He starts talking. Tears are coming down his cheeks. I'm, trying to maintain my professional composure, and it was just a very emotional moment. And I just kind of realized in that moment, I was part of this process. This guy's going to be able to communicate with this kid now. He's going to have a new bond with him. And it was at that time I thought, I need to leave my other job. I need to resign. I feel like this is what I was meant to do. And so long story short, here I am 10 years later and doing work like this, and it's very, very emotionally rewarding. And I could tell you probably 20 more stories like that where it's just very life-changing, because especially when COVID hit, most folks use the phone as their connection to the outside world. That's how they find out about their family reunions, the next golf outing, the next breakfast with their buddies. And when they stop communicating on the telephone, they start to become hermits. And we're all social animals. We once we start becoming hermits, our physical health starts to go on the decline as well. So it's very important to stay connected. And fortunately, I get paid to do this kind of work and help people stay connected and stay healthy. So I'm very fortunate to do the work that I do.
Thank you. I think that just brings, such an important point home. Just that whole thought of everything that we've talked about today, and how it's not one thing. It's not your eyes, it's not your ears, it's not your balance, it's not your connection. It is all of those things. And when one starts to decline, it is so easy for us to then push back and try and become less involved. We don't want to be a burden on anybody. We don't want to be a burden on our families. But the important thing to remember is there are people out there that can help you and that are dedicated to that thought of changing lives and helping people through their different expertise. So, just keep that in mind whenever you have a challenge and you think, oh, this is nothing. No, it is. It is, because if it's affecting your quality of life, it's definitely not nothing. So with that, I'm going to go ahead. We're well on time to go ahead and open it up for questions. So, okay, let's start right here.
Dr. Keenan, I was recently diagnosed with low word recognition.
Yep. Go a little closer.
How about this? My last audiology test diagnosed me with a low word recognition, and I didn't quite understand exactly what that is. If you could explain it a little bit more.
His question was if you couldn't hear, everybody can hear me. He got diagnosed with low word recognition score. So basically, that's part of the test where we can do individual words and sentences, and we read them off to you with no visual cues, so you can't lip read or anything else. You're relying completely on your ears, and it's out of a score of 100%. So the lower the word recognition score, a little trickier the fitting of the hearing aid can be. And a lot of that has to do with the counseling and the expectation of the patient. It's very important that you take ownership of that and that you truly understand the ramifications of the hearing loss. And that's why we always recommend a spouse or a family member to come along. It's a lot of information at once, and it's important that your family understand that. So what you can do with that is You want people to be looking right at you when they're talking. Don't say huh or what, because then they're gonna shout. Say, could you say that again, please, slower? Because if I slow down my speech, it gives you extra time to process and it's better. So good amplification, good directional microphones and word and noise management, and then just using those visual cues. And there's a lot of things we give people handouts on things the speaker can do to the person with the hearing loss and you vice versa. But really good visual cues is going to be very, very important in your success.
I think that's so important, also that idea of talking with your family members, because I know that, when I'm dealing with clients even that are hard of hearing, it can be challenging. It can be challenging being the other person on the other side of that hearing loss, dealing with someone who's always saying, what? So the more that we can, just incorporate some of these tools, I think the better.
So one thing that I tell my patients too is everybody's talking about ears now. Everybody has something in their ear, an AirPod, an earbud, whatever. So it doesn't have as much stigma as it does. I think you're better off being upfront, especially with friends and family members. I have a hearing loss. It's nothing worse. I've got some vision problems, but it's hidden because people can't see it generally. So it's a hidden handicap. So people want to help you, they don't know how to help you. So if you just say to them, even if you go into a restaurant, tell the waitress, hey, can I be somewhere where there's good lighting? I want to be on the edge. I don't want to be where there's lots of noise. Don't sit me next to the kitchen. Just be upfront and be proactive, own it, and let people know, because they want to help you, but they can't see that you have a problem. They're going to maybe mistake it's a cognitive issue, you're being crabby, you're ignoring me, and that's really not the case. So advocate for yourself and let people know, but it's important because it's a family issue. It's not just an individual.
That's a very, very good point. Okay, back there.
I've got, you're talking about hearing loss. I'm totally deaf in my right ear. So as far as, like you were just saying, own it and let people know about it. And I really struggled with doing that through my life. I had my hearing loss back in 5th grade through months. But you mentioned about cochlear implants. Is this, and I've gone to another audiologist and talked with him, and he kind of, because I mentioned I wanted that. I did have an amplification device, and that didn't help at all because I'm totally deaf. So all I was doing was amplifying to my good ear the room amplifying. Question to you is this something I could look into as far as for myself, being completely deaf?
Yeah, actually what you have is called single-sided deafness. Depending on your ear structure, they'd have to do an MRI to know for sure. There are bone-anchored hearing aids, and there are other devices for single-sided deafness where they electrically stimulate. In some cases, now the FDA controls the world, and they control cochlear implants and when they're appropriate. So if you fit into the criteria, which there's several, a cochlear implant could potentially help you too. It depends on the type of damage that was done at the time. There are also, what you were referring to is a cross aid. So that's where you have a live hearing aid on one side, and you have the other side is basically a speaker that picks it up and routes it over to your better ear. Now, if you have hearing loss in the better ear, it's called a bicross. We're amplifying the sound and crossing it over. If you have absolutely normal hearing in one ear and just the single-sided deafness, that's called a cross aid. Now we're just crossing it over. We're not really amplifying. In that case, again, there's huge differences in technology, huge difference in people's expertise in fitting that type of a device effectively. I will tell you, it's a very tricky situation. I probably have 80% of my patients love the cross and go with it, and there's 20 that it's like liver. You either love it or you hate it. And the longer you've gone with it, the more your brain has purged and has now created more pathways, and it's focusing on the better ear. So the longer you've had it, the less likely amplification is successful in my experience. But a review with an ear, nose, and throat is not a bad idea occasionally, because we're always making strides in those areas, but they would be better suited to answer the question if there's any medical intervention, but there's definitely could potentially be.
So is that something I can come and see you on?
You can, or you can go directly to an ear, nose, and throat doctor.
I did, you know, the throat consultants.
Yeah.
I don't know if Dr. Daryl Helsinga,
Oh, yeah.
okay.
He's been in the area a long time.
I went to him.
Okay.
He's the one who fitted me with the amplification.
Okay.
and all that. It didn't work. The one that he put in this ear did bring my hearing up.
Okay.
Perfect. Then he put on this side. That.
Yeah, again, some people's brain system has switched over and it just doesn't. But Dr. Daniels is in his office as well, and he is an otoneurologist. So he is an ear surgery specialist. So he can do ear, nose, and throat, but ears are his specialty. So Dr. Elzinga, if there was a chance of it being a surgical option, would definitely know that and can refer you. And again, if it hasn't been in the last couple of years, there's been a lot of change. Yeah, great office to be in though.
Great, thank you.
Yep. And just a reminder on some of these questions that are going to be pretty specific, it's great to just mark on your, on your sheet today that you would like one of these guys to reach out to you because you have a specific question, because it's likely going to be something that is going to take a few times to really dive into, and sometimes, it might not be the first doctor that you see where you're going to get your effective answer that you're looking for.
And on my website, there's a live chat, so if you don't really want to interact a lot, you don't necessarily want a long drawn-out conversation, just go to the chat, post your question, and it will come directly to me as an email, and I can email you back. So if that's an easier way, a little less intimidating, use that.
I'll just stand up and maybe people can hear me. Two things. One is I got to share a quick story with you, back to audiology, just like everybody else I did. A friend of mine who is now like 66 or 67, he had been using, he said, oh, I can never hear. And I said, well, did you ever check your hearing? Yeah. So 3 times now he's gotten those mail order hearing aids, and he just, and he still can't hear. So finally he went to a real audiologist and, used his Medicare benefit. And now they're crossing their fingers. But I mean, he's been struggling for years, and I think, how silly. But anyway, my question is, I just recently read that dementia and hearing loss are related. Can you talk about that a little bit?
Absolutely. So I believe one of the original long-time studies was 2009 at Johns Hopkins University, and it has been a known fact for a long time that hearing loss contributes to the faster progression of those things. It's not necessarily the cause of any of that, but if you are not giving the brain all of the information it needs to process the speech, your brain is what's hearing, your ear's just transmitting the signal. So if your brain isn't getting the right information, it starts to atrophy. And so they showed MRIs over the years, and the people who had amplification did better, and the disease process was slower. Because again, use it, lose it, stimulate it or not. So I see it in very young kids. I saw it ignored and put into special education. I've also have patients who thought they had dementias, Alzheimer's, different things, and they really didn't. They were not hearing it properly. So again, it should start at those grassroots. Can you hear? Can you see? Then go on and try to remedy the situation. But unfortunately, the longer you wait, the more difficult it is. And we definitely know now versus 30 years ago. When I started in audiology, you fit one ear. Well, the VA got rid of that. 1970s, they said, no way, that's malpractice. You need to fit both ears if you have hearing loss in both ears. The other thing was doing it sooner. We were not allowed ethically to fit a hearing loss that wasn't 50% or more. Well, you've lost a lot of time. Even with kids, a 30% hearing loss was acceptable in the classroom. So we've come a long way, and we've got things that can help sooner than later now.
I'd like to ask about nerve deafness in the ear. My husband had that, and his hearing aids just didn't help. It was right. It was at the range of my voice. Can you believe it?
Could that be more about listening?
It's a cruel irony.
Well, you have to go up.
It is.
Up or down or something. But anyway, What's the scoop on hearing loss, nerve deafness?
So
and hearing loss?
we really call it sensory neural. We kind of group it together. They are two separate issues. There are inner hair cells, outer hair cells, blah, blah, a lot of boring stuff. But basically it boils down to there's different types and degree of hearing loss and different people are affected differently. So again, that my suspicion would be that that was a word recognition issue. And if you're not counseled correctly and given the clues and the tips and the tricks to use with the hearing aids, you're just going to blame the hearing aid and think it's rotten, it's not working. But nerve damage is the most common. So probably 95% of people with hearing loss, it's nerve damage. Only 5% is really medically treatable from that perspective. So in that case, potentially cochlear implant might have been a better selection. And that's where you have to be careful of the provider you're going to see. Do they have your whole body and health and well-being? Are they talking about how your life is going to be affected, or are they talking about the widget, the thing, the next best technology, and that type of thing? That's a different conversation. It should be medically driven first, and you should be able to understand that hearing loss, and that's where it's important for you to be along and for them to be sure you understand it.
I just wanted to add something, taking off my caption call hat and putting on my hearing loss advocate hat. I just wanted to piggyback on something Pam had mentioned. I don't think a lot of people realize when you start to lose your hearing, you have a muscle that converts that sound into words when you're hearing. And the longer you wait, the average person waits 7 to 10 years too long before they get help for their hearing, right? During that 7 to 10 years, that muscle is not being used properly. It's like anything else. When you learn math in high school, if you don't use math, who remembers their trigonometry from high school unless you do it for work, right? You're not using it. It's the same with hearing loss. So 7 to 10 years later, somebody's getting fitted for hearing aids. That muscle has pretty much, it needs to be exercised to get it back working again. So a lot of times people get fitted with hearing aids and it doesn't work, quote unquote, and they throw it in a drawer and they don't use it. They have to exercise that muscle to get it working again. So the point I'm trying to make is the sooner you get help, the less you have to exercise that muscle to get it working again. So it's very, very important to get help as soon as you notice you have hearing loss. Or just take a baseline hearing test every couple of years. That will tell you when you're starting to lose your hearing. So just wanted to add that. Thank you.
Awesome. You guys, thank you so much for all of this. Did you guys get some great information from these guys? I'm telling you, every time I think that, I kind of know this and I have some ideas by reading their website. No, I knew nothing. There was just so many great ideas that are that you really get when you are able to come here. So I'm so grateful to them, and I'm so grateful to you guys for showing up.